There are a few types of neonatal jaundice. I will focus mostly on unconjugated or indirect. I can do direct hyperbilirubinemia as well. Just let me know. I like this picture because you can see that somebody's pressed on the baby's chest and the color that's left behind is yellow. It's very difficult, and there's been studies that even visually you can't tell a baby's jaundice level. So even if they look jaundice, the level may not be that high, requiring treatment, or if they don't look jaundice, it could be high. So you can't rely on visual alone. All babies have some level of jaundice, so some level of hyperbilirubinemia, and that is because they have a higher red blood cell mass and decreased red blood cell lifespan, meaning those red blood cells are breaking up, and that is what the bilirubin is coming from. Bilirubin clearance is also compromised by impaired activity of the UGT enzyme. This is a nice little pathway, and babies also have increased enterohepatic circulation. So meaning they break down the liver, goes into the GI tract to be secreted or excreted, either poop or urine, and it sits in the GI tract, it gets reabsorbed and goes back into circulation, so that bilirubin is never cleared. So physiologic jaundice would be any newborn that is breaking down red blood cells and it's just not clearing it fast enough. So if the baby's breastfeeding, is not peeing a lot or pooping a lot, that bilirubin that's sitting in the GI tract will get back into circulation, and the baby won't be able to break it down fast enough, and it will be, we'll treat it with that blue light that goes on the skin to help get rid of it. We worry about bilirubin because we know in the first few days of life, the brain doesn't have a good protection around it. So the blood-brain barrier isn't strong enough to prevent those big molecules from coming in yet. So bilirubin can deposit actually in the brain and cause kernicterus, which is seizures, and causes long-term neurodevelopmental impairment. There are other scenarios like pathologic jaundice in which the bilirubin can be elevated in the first 24 hours of life, the first 12 hours of life, and we'll typically see that with ABO incompatibility. So that is when the mother is O blood type, the baby is A, B, or AB. The mother makes anti-A, anti-B antibodies, depending on the scenario, of the IgG subclass. So IgG can cross the placenta. The other blood types, A and B, make IgM, which cannot cross the placenta. So the mother has to be O, the baby will be A, B, or AB. And those antibodies will cross the placenta and attack the baby's red blood cells. So the baby will have a higher rate of hemolysis or red blood cell breakdown, which releases the bilirubin, and the infant's liver, we already know, can't keep up. We also know that babies have a high enterohepatic circulation of bilirubin, so those levels can go really high very quickly if you have ABO incompatibility. Treatment is a moving target, so every day the baby gets older, the higher threshold we have for treatment starting. So the first few days we want to start it because we don't want to risk it getting into the brain. And then as the baby gets older, the number goes higher and higher, so we're able to stop treatment or not start and just kind of watch depending on what the level is doing.